Bismillahirrahmanirrahim, and thank you, Professor Bilal. The case which I'm going to present and share with you, the title is When All Options Are Lost, One Still Remain, How to Tackle Large Coronary Artery Perforation When Wire is Not in Place. I have no disclosure. This is a lady who was 66-year-old, had recent interior wall MI. She was given thrombolytics in periphery and was due to angina 3. She was referred to us. She is diabetic for the last 15 years, had hypertension for the last 10 years. On clinical examination, her blood pressure was 140 by 90, pulse 76 per minute, it was regular, and the rest of examination was unremarkable. ECG had STT changes and echo anteroseptal hypokinesia with EFO 50%. She underwent angiography that I'm going to share. This was her left system, areocranial. This was her RCE. So as the anatomy was very nasty and calcified and multi-vessel disease, so we discussed with the surgeon, but due to high risk, the surgeon turned her down. And I started after discussing with the family, we started the PCI, and I had difficulty in wiring the LED, and spent almost 20 minutes while wiring the LED, but the wire would go either to the diagonal or would loop into the aneurysm. So I decided to, my wire went into the diagonal. Yeah.
Diagas disease, patient is diabetic. Obviously, surgery is one option which could have been considered. And if this obviously surgery is not is deniable, then I most of the time personally try to do if I have to do a double or triple vessel disease, I try to do the easier vessel first in case something goes wrong to the other one. I have some backup in there. Obviously, PDA I didn't see the PDA filling from anywhere. So I would leave that alone. So circ is easier and quicker vessel. I would probably fix that and then go to the LED. Now, again, aneurysm, whenever there is aneurysmal dilatation, wiring is always a challenge, especially if you have to get into the branch. So the options, if obviously you try initially and if nothing works, then there are options, obviously balloon occlusion and then going into the side branch is one possibility, and second is angled microcatheters can be used to get into that. So those are the other possibilities which you can do.
Let's start off with you. So if you are doing this case, which wire?
Very prone to like dissections, perforations. They are very prone to the vessels like this. So what I would suggest initially, I would go with the workhorse wire. Like I would like to try with the BMW first to see how it behaves in this vessel. Regarding the vessel to be addressed, in this case, I think I would go for LED first, because this would be the deciding vessel for me. I mean, whether we can go through it or not. After that, I'll decide the fate. If it's successful, then other vessels as well. Otherwise, then we have an option of surgery as well. After this BMW, I will go for wire escalation, and then we will go for any CTO wire like crosset.
Dr. Regla, I was wondering, would you like to go with a wire straight, or would you like to go with a wire and a microcatheter support?
Perhaps microchannel would be a wiser choice, because you have always the option of sealing the wire, and looking at the lesion, it looks like the workhorse wire will not work, so obviously microchannel is a perfect choice.
Perfect choice. Okay, doctor, let's see what you started doing.
So as you people discussed, I decided to do the PCI of
Sterility index. So what are the things that you were looked into for this factor?
Actually, this patient was frail lady, and she had advanced osteoarthritis, knee joint, and the surgeon, due to high frailty index, she was turned down by the surgeon, so I had to do PCI. So I had difficulty, as you saw the anatomy, it was the LED was a bit retroflex after giving the diagonal. So I had difficulty in wiring the LED. The wire would go either into the diagonal or would go into the aneurysm, loop into the aneurysm. So I decided to do low pressure ballooning to create space for the second wire and microcatheter, and also to change the angle, because we didn't have the angle microcatheter or dual lumen microcatheter at that time in CathLab. So after ballooning with 2 into 15, low pressure, 6 atm during, as you know, sometimes you are casual, so while I was pulling the balloon, I pulled the wire, and when the check injection showed large perforation. So now what to do? I had already difficulty in wiring the LED and had lost the wire position from the diagonal.
You injected through the microcatheter here, or what?
No, microcatheter was because I thought I could wire it. I took the pilot 50 guide wire, but it would not go into the LED, despite making the different shape of the tip. And then I decided to do low pressure ballooning. So I had some space for the microcatheter and second wire, because if you see, the lesion was very tight.
So low pressure balloon in the LED to direct the wire in the diagonal, that's what you did?
No, my wire went into the diagonal. I did low pressure ballooning before the bifurcation.
Oh, okay. Before the bifurcation.
Before the bifurcation at the lesion which was the tightest, just before bifurcation.
My question over here actually is that you have this low pressure idea, but when you say low pressure, which balloon are you talking about? It's a different ball game. Low pressure 2 balloon, low pressure 2.5 balloon, low pressure 1 balloon. So what are we talking about?
It was 2 balloon. I have mentioned 2 balloon, and the balloon we were using is a mini track from the Abbott.
You have that picture of the low pressure balloon. I just want to see where your wire was in the diagonal when you did the balloon, because...
Actually, sorry, because I was not expecting this perforation, so we have not saved that fluoro. So it was, the wire was in the diagonal.
You are sure on that?
Yeah, it was in the diagonal. Retrospectively, probably there was another branch along with the diagonal. Maybe the wire was there.
Yeah, that would have been my concern. Before doing any low pressure balloon, I would definitely make sure that my wire is there. And obviously, once you do the balloon, then sometime it could be difficult to get in there also.
Yes.
The diagonal was a sizable branch. It was not a small branch.
Okay, so let's proceed.
So immediately we called the surgeon and started balloon tamponade, did echo that showed large pericardial effusion, put immediate pericardial drain, started the patient on IV fluid and vasopressor, and again called the surgeon. So this is the drain. After prolonged balloon inflation, we still had tamponade, still extravasation. So what I did at this time, because surgeon was not very keen to shift the patient, and out of desperation, I did further high pressure inflation, so to change the angle, and if I could wire it. I had already taken the femoral artery, another access. I was doing from radial, and at this time I could not puncture the vein for autotransfusion. So then this happened. So this was after.
Were you sure that your wire is in the distal LAD? That would be my other concern. That if
Yeah, this is a question for you.
yeah, because
Where is my wire?
I would have been very reluctant to balloon further unless I am 100% sure that my wire is in the lumen and not somewhere outside. And it looks like this may not have been in the lumen and you ballooned, and that made it probably further worse.
So this is, I told, because I had almost exhausted all the options, and the surgeon was not very keen, and the lady was very frail, and this wire is in pericardial space.
I think it's not the question of being keen. It has to, surgeon, you don't have any options. Obviously, you were lucky, probably may have been able to save this, but patient, that's why when I was saying, Badar, that I try to do something simpler. Although when it is a CTO and I know it's going to be difficult, I may not be able to cross it, then I would say, okay, I will do that. That's going to make me decide whether I basically send him for surgery or proceed with angioplasty. But here, other than the diagonal, LAD was a short segment, and I was pretty confident that I'll be able to cross. That's why I said I will have, because now, if you have right as a problem, circ as a problem, and this one patient would crash on you. So he's been lucky that he was fine. What was his EF, sorry?
EF 50%.
50%. Do you routinely check EDP before angioplasties in such patients or no?
Sorry?
EDP, left ventricular
No.
arrest.
In this patient, because EF was good, so we didn't check for the LVDP.
And his hemodynamics were okay?
Yes, her blood pressure, now her blood pressure was down. We started her on fluid and as well as vasopressor, 3 vasopressor.
So Bilal, what will you do, by the way, in this, at this time?
You see, when you cut off a difficult, but before I go, I'd like to have.
Yeah,
we're missing out on this.
Extremely difficult situation, and you may lose the patient if you don't control your nerves. But anyhow, when you don't have a surgical backup, you have to strive and save the patient, and again go and rewire and of course save the diagonal and LAD.
I don't know, I don't know where I'm going to wire and what I'm going to do. Did you call for help, any other help other than the surgeon, your colleague or somebody?
Yes, in anesthetists we had 2 other colleagues besides the fellows and the resident. We were all around, and the anesthetist was around. We were about to intubate her. And
Yeah, no, I'm talking about another interventionalist, senior, not junior, who is there to really give you moral support and other help as well. Never hesitate to call and these situations. Anyone who even somebody you don't like, don't hesitate to call them for help in this kind of
yes,
situation.
we had already
So,
2 available.
did we do an echocardiogram over here?
Sorry?
Did we do an echocardiography?
Yeah, echocardiogram was done. That showed large pericardial effusion, and tamponade we had already put a drain.
So when you were putting in your link, putting in your drainage over there, how did the patient respond immediately? Did the patient give a kick back quickly, or did the patient take
after aspiration, the patient blood pressure would go up.
And
then,
did you consider autotransfusion at that moment?
Yeah, I as just mentioned, I tried to puncture the femoral vein, but I could not.
So, your point.
I was just wondering whether you ever checking diabetics, particularly in this age group, to see how their diabetic control is, because I think that should also give you a lead as to what to expect with arteries. I mean, that looked horrible to me. So you probably wasn't well controlled before you intervened.
Sorry? The
Basically,
diabetes was not controlled. HbA1c was around 10 to 11. I don't remember exactly because it is almost...
Well, none of us do, actually. Not even the physicians. Obviously, interventionists have a job to do. They are focused on only intervening rather than looking at other aspects and to expect what to expect. I think that's in my mind, I think that's very crucial before you intervene, to make sure that, your patient is in good diabetic control. And if he or she isn't, then you need to do something more like, having their sugars normal. Otherwise, you can have arrhythmias, you can have hypotension, and patients I've seen go into pulmonary edema during the procedure. So I think these are all the precautions that one should take before, especially when you didn't have surgical choice and the family were not too keen. And obviously nobody would like to see patient, a dead patient, even though you did everything. But at the end of the day, that matters to me. Thank you.
So let's see what you did further.
Just quick, I would like to know, Ikram, what would you do in this situation if you were there doing it? Will you put your hand on your surgeon's neck and tell him that you have to take it, or you'll keep trying?
But what happens in CathLab has to be fixed in CathLab generally. That's the problem with us people. So you're very lucky basically because to begin with, that was a very difficult case, and then you had no access, there was no wire, and still you were able to manage all this in this catastrophic situation. So you're lucky basically, I think.
They must have done something good that day.
I think in this case, the luck favored me as well as the patient. So I take another guide from the femoral, and this time I could cross the wire under the
To use again?
It was probably whisper. It was whisper under the supercross support. But due to this like situation, I could not see all the steps. My wire went into the opposite.
Yeah, I would have really not used whisper. I would have used a routine wire, either BMW or run through or something, because whisper goes in the subintima dissection very easily. And the other thing is I try to go through the loop, but again that tight lesion in that LED would have been a problem. Anyway, go ahead.
So
Right. So what next?
Then after wiring, I ballooned it.
So were you sure now that your wire was in the lumen, or you
Yeah,
still?
because when my wire went into the septal, I pushed the microcatheter and then redirected into LED.
Okay.
So I had difficulty in tracking the graph master because we didn't have the papyrus. Then I had further dilated with 275 NC. Then I could track. This was after
So
the.
were you able to find out where exactly the perforation was?
Yeah, actually perforation to me, it was at the ostium of the diagonal along a small branch.
Yeah.
So we can see the diagonal is sacrificed in this case. So this was after the deployment of graft master. Since we had injured the proximal ED due to repeat ballooning, we put another drug-eluting stent proximal to the. This is the LO caudal, and this was the final angiogram. We discharged the patient on third day, and she was stable. EF has come down from 50 to around 35 to 40. But 1 month after the patient presented with chest pain and shortness of breath.
That's the problem with covered stents.
Graft master did the thing.
So we again took the patient to CathLab and did the ballooning and put another stent distal to the graft master, and also
Fix the circle.
did PCI to the sir. This was the final angiogram. The lady is still alive, almost 1.5 years.
I think you are a great save, and must say you are very, very lucky that you were able to wire and do all this. Excellent save.
So this was the final message. Hard work pays, fight till last, believe in teamwork, perseverance, do CPR, but it was not required in this case. Finally, miracles do happen, and have faith in the God.
Good
That's
case.
perfect.
Good save.
Yes,
Thank you.
perfectly right, but can we have the very first view of the LED?
बिल्कुल सर.
Can you have the first view of LED, please? So you see, when you have this kind of an LED, you already know that this is basically, if you look carefully, that the distal LED, the distal LED fills from a very small collateral which is over there. So your desire actually is to get into that very point. Now, it is always the most tricky part is to place your wire at the right place over there. So anyone has the concept of bringing a wire in over a balloon, inflating the balloon so that the wire stays central. So anyone with that concept?
Inflate the balloon, you're talking?
You have a balloon, bring it as near as possible. Then you inflate, and it's a big balloon now because over here it's a big balloon. So you need to make it central. So you have a balloon which is about 2.5 or something like that. Keep it there. And then it may be your over-the-wire balloon or something like that. Keep it there.
This is what the microcatheter will do, and you are making your balloon a microcatheter basically.
No, basically, you see, when you're doing this is the over-the-wire balloon.
The same thing as the
But the microcatheter, the difference is that the microcatheter may float in one direction. But if the inflated balloon will usually tend to stick to one place. This trick, of course, only works when you are sure that the lesion is centrally placed. But if the lesion is not centrally placed, then you never...
Yeah, but sometimes it could be very difficult to say, first of all, it's centrally placed or not. Then also the balloon, I know you'll have to use like, यहाँ पे 1:1 303.25 balloon के वो centrally, or that the likelihood of causing a dissection to me would be more if I go that close to the lesion, and if I am not in the right place, then it's going to go under the plaque more likely than anything else.
Another thing is about our problem is that many times we're faced with the economics of the whole thing going on. So how many of you would consider going in with not the workhorse, but something which you feel will actually cross as your first wire?
Actually, when we are using a wire, we should know what is the quality of this wire. Like for the Pilot 50 is a hydrophilic wire. It's not a CTO wire. It will slip into any micro channel. It will slip into the micro channel, and it's very prone for dissections again. In this case, workhorse wires is always advisable because it will give you an idea what sort of the lesion is, what is the reboundness of the wire, and what wire to be used next. After that, it should not be in hydrophilic wire when there is occlusion, total occlusion after that.
मेरा case. Hassan Suhail, he is presenting the case.
Right. Thank you. I think we have our next presenter with us.
Thank you.
Thank you, sir.
Great save and good case.
And after that, we have, I understand, a presenter from Punjab Institute of Cardiology also. Is he here? Yeah, he is here.
Yeah, let's see.
After this one.
We have time. So Hassan Suhail is our international fellow from Tabard Institute, and this is
So it's
my
10
case.
minutes for you and 10 minutes later on for PIC Bank.
I think we keep talking about JS, KBT and all that, keeping the balloon in the diagonal for main vessel. So this is the disaster from that. So I'll show you it's never
This
not
reminds me
always
of
safe.
this reminds me of a case that I was doing way back many years ago, and I ended up with a false lumen entry. In fact, I presented this case later on in Pakistan live or in one of these our meetings, and I had a sure shot dissection going into the wrong place. But the second vessel was also carried out first, and then this was done.
Ready?
The patient afterwards became totally comfortable.
The loading presentation.
And we told him that you have to come back after 6 weeks, and we thought that this is going to be an investment procedure and we'll come back and do it. The gentleman did not turn up, and then after 2 years, he suddenly came into my outpatient again. And this time he was again having symptoms. I said, why did you come earlier? So he said nothing was doing. But anyway, so I knew what my plans were, and now I was quite sure that the system was healed over there. So, but hold and behold, start again the same damn thing. Because why I'm pointing this out is many times you say that investment procedure is done, so now it is healed, so it's okay. But then the best thing is that you take hold of a second wire and you do a parallel wire technique. And now that you've got that thing sorted out and you know this is not going to work out, and then you try and go in. And once you're in and you start hitting some septals or some diagonals, etc., then you sort of feel that yes, you are in the true human, and then you keep on going through. So I remember in that one, I finally had to take up a miracle 6 to do the parallel wire. And of course, that is not something which is always recommended, but then that is something that you always fight for.
Time
Here
is
we
short,
go.
so go ahead, please
Hasan
start.
Sohail, please.
Assalamu alaikum, good morning to all. I'll be presenting this interesting case of a 65 years old lady who was pre-diabetic and had been treated previously for CA colon. She underwent an angiogram at an outside facility for CCS2 and NYHA2 symptoms, which revealed a single vessel coronary artery disease involving the ostial LAD, which was severe, osteoproximal LAD, and a moderate to severe lesion in the mid-LAD. Her ejection fraction on echocardiogram was normal without any significant
Dr. Sohail,
valvular-
just a second, please. I think we have got a problem. The display over here, and that is not working properly. Can you have the over there?
Maria, can you ask somebody to change the display on this screen also? This screen is different display than that one.
Maybe still the old case is presenting over there.
Okay, you go ahead in the meantime.
Yeah, please go ahead.
The ejection fraction on echocardiogram was normal without any significant valvular abnormality. So in view of persistent symptoms, we decided to go ahead with PCI. These are the pilot shots from an EBU 3.5 guiding catheter. The caudal view here shows a tortuous circumflex system without any significant disease, while this ostial severe LAD osteoproximal disease is evident, and the cranial view confirms a moderate to severe disease after a good-sized diagonal branch. We wired both the OM and the LAD with workhorse PMW wires and decided to pre-dilate the lesion with a non-compliant 3.5/12 balloon up to 14 ATMs. Our plan was to stent from left main to LAD with two overlapping stents. We decided to play, the overlap was planned just after the origin of the diagonal branch. We decided to stent with a 275/26 drug eluting stent at 12 ATM in the mid LAD. There was, however, significant plaque shift, which pinched the good-sized diagonal branch. So we wired the diagonal branch.
Although it's like strange, go back one picture. If you look at that, diagonal ostium was, go back one more, diagonal ostium was clear of any significant disease. It didn't seem there was much disease at the LAD where the diagonal was coming. But after, I don't know, there was dissection or something happened probably that resulted in shifting a plaque, the flap into, yeah, it's here now. So flap into the diagonal branch, resulting in that kind of a severe compromise to the diagonal. And after putting the stent, when we saw that ostial thing, I was concerned that there's a large diagonal branch and, okay, go ahead.
So let's give it the chance.
So now the question was whether we go for a two-stent strategy here, considering such a large diagonal branch and the only sizable diagonal coming off, supplying the anterolateral area, or whether to keep it provisional. We decided to keep it provisional using the modified gel balloon technique. A 2O10 balloon at 10 ATMs was inflated simultaneously with a 3.5/30 drug eluting stent from the ostium of the LAD overlapping the previously placed mid-LAD stent. There was, however, a problem with our inflation device as well in this case. As we were trying to inflate, the inflation device dial didn't go up, but the fluoroscopic images showed good balloon dilation. We were stuck at around 4 ATMs initially, and then suddenly the dial jumped to about 12 ATMs, the pressure at which we were intending to deploy the stent. So we gave a small puff just to make sure everything was okay, but lo and behold, we had a perforation there.
So I think let's stop here. So what should we do?
You see over here, it is quite clear that the perforation is coming from the point of junction.
Yeah.
And when you have these points of junctions, you try and, of course, put a balloon over here and you seal up this vessel. And once you have sealed up the vessel at a good pressure, then you give a small dye and make sure that you have actually sealed it. Because many times, actually, when you take up your balloons, you are not sealing the whole place. And once you have got it sealed, then you, of course, wait out your time. Now, of course, the simplest technique over here would be to come back with a covered stent, place it over there, and sacrifice the diagonal.
That's a good size diagonal I didn't want to.
But when you are talking of this good size diagonal, the question is you need to have a good size living human being and sacrifice the diagonal.
The patient was luckily stable, so.
Right. So let's see what you did.
So we started off with the balloon tamponade. The 3512 non-compliant balloon on the table was taken immediately. We balloon tamponaded intermittently for around 30 minutes. The results weren't very different. We took another balloon, a bigger balloon, a 375 non-compliant balloon with 15 millimeter length. Balloon tamponaded for another 30 minutes, and this is what we got. We had,
you see, when we do a balloon tamponade for 30 minutes,
no, not
intermittently,
not continuously,
intermittently.
yeah, like 10,
so
15 minutes.
it is at such moments that I am reminded by my seniors that there used to be a balloon which is called the
Yeah, I have used that, the perfusion balloon.
Perfusion balloon.
We used to have one.
And these perfusion balloons, I don't think
No, it doesn't
no
exist
longer
anymore.
exist.
No.
So that is something that I think that one can always request the industry to sort of
I know, but the
rethink.
reason is that people used to think that although it is called perfusion balloon, but the perfusion really going through that balloon is so small that it's not significant, and that's why they abandoned it, and they don't even make it anymore. So, but which one? Triumph. Okay. Perfusion balloon. Oh, okay. It's available in Pakistan? Oh, yeah. Okay.
Right.
Okay, good.
And then
So we had repeated echocardiograms on the table. Luckily, there was only trace effusion. The patient was hemodynamically okay. There was no chest pain. He was being maintained on IV nitrates. And since there was no further extravasation, we decided to post-dilate the left main portion of the stent with a 408 non-compliant balloon up to 20 ATMs and remove the wires, shifted. This is the result after post-dilation of the left main, and tried to keep it conservative since the hemodynamics were okay. There was we shifted the patient to the CCU, and we were doing early echo monitoring. 4 hours post the procedure, she developed moderate effusion with signs of tamponade. There was early diastolic collapse. There was significant variation at the mitral inflow. So we had to shift her back to the CathLab. We did a pericardiocentesis on her. The pigtail is evident in the pericardial cavity. The relook angiogram, however, wasn't very different from the initial incident that had happened. And there was some trickle of flow which was going into the diagonal now. So we decided not to intervene again at this point, and we shifted her back. The pigtail was there for about 24 hours, and after making sure there was no reaccumulation, she remained stable. We removed the pigtail and drained and discharged her the next day. She's in a regular follow-up and doing well.
mashallah. And when you were doing the case, did you do an echocardiogram when you had that perforation?
Yes,
before,
we were
before
doing
shifting the
repeated echocardiograms on the table. While we were doing balloon tamponade, the echocardiography team was there.
What I mean is that once you had everything secured and you were about to shift the patient, you did an echocardiogram.
Yes, we did an
You must have had some rim over there at that moment.
Sorry?
Did you have a rim over there? A rim of...
Yes, we had trace pericardial effusion, which was there. We had her on the table for over an hour. And we were repeatedly doing, every 10-15 minutes, we were doing echocardiograms. And there was no increase. She was hemodynamically stable. So we...
Perfect.
One
So your
issue
point.
is that usually people think about the reversal of anticoagulation. Where your hardware is there inside and the coronaries, so it's not recommended to reverse the anticoagulation with the protamine sulfate because it's going to make the situation worse. You will have thrombosis on the top of pericardial effusion. So nowadays it is out of question because yesterday somebody was discussing about the use of protamine sulfate in this case. When your hardware is out, and one important question is that after using because we don't have any data, if you use a cover stent or multi-layer stent, should we go for this clopidogrel or we should go for ticagrelor?
So would you like to take on this question?
I think it all depends on the personal choice. Well, I think clopidogrel probably will be a better choice.
It's fine. Because we have to prevent ISR, not the stent thrombosis. So I don't think, in my opinion, it would not be any difference in this.
Like in the first case of the Dr. Jabbar, immediately after, I think it's after 2 months, so it was fully occluded. With 1.5 months, there was stent thrombosis inside this cover stent.
Thank you, Dr. Saab. I think we have got another 10 minutes and then we have got a Punjab Institute of Cardiology's case coming. Thank you. Well done. So far, these are the 2 perforations that you have seen. This is a different kind of a flavor coming from our institute, and I'm sure that you will enjoy this one. You see, no matter whichever perforations, whatever you have, no solution is ever the best one. You always want to have something better and better. The concept of putting in, trying to get the body fat out, pushing that in, your coils not staying in the right place. So all of these things are tried, but of course the good part of both of these cases are that, they went home finally. And I remember one of my perforations long time back, and that was actually because I could not cross my stent, and there's a bit of yanking on that point. And this was again a CTO case that was done. And once that CTO case had been done, I, for economic reasons, decided to keep my wire inside, right? And when you're doing those yankings, you're pushing your stents in, etc., you're trying to create, you at times lose sight of the distal wire, the tip. And this was, though, not exactly a very bad wire to the Pilot 50, but this Pilot 50 did manage to cross a micro channel, right? And I completed my case, I was happy, everything honky-donkey good, no problem. And you are always focusing only on your basic areas. You're not really focusing on all the other areas. So that was a basic lesson to be learned, that once you have completed your case, always look at the distal most part. And then another experience that has come in is that many a times when your patients are complaining of slight discomfort, it's many times not because of what you are doing over there, it's because your wire has traveled into a small vessel, and that is causing the pain. Okay, so Dr. Rana Mohammad Tayyib from Punjab Institute of Cardiology, one of our good senior registrars over there, please.
I think we can go ahead just without discussion because your time is short. So.
But I think this is a short case.
Yeah, that's good.
This is a case of primary angioplasty.
Okay, great. Go ahead.
Ji, Dr. Sir.
So a middle-aged, 50 years male, hypertensive smoker presented to our emergency department at 12 night with the history of chest pain for 6 hours. So ECG was done and short echo was performed. So ST elevations from V1 to V6, and short echo shows moderately severe LV systolic dysfunction with the hypokinesia of LAD territory, but blood pressure was 140/90, heart rate is 92, and saturation was 96%. So the initial ACS protocol was given, consent was taken, and patient straightforward shifted to primary CathLab. So here is the angiogram, right coronary artery that is non-dominant and normal.
So, left system, LCX is dominant, normal, and there is a huge aneurysm at osteoproximal of the LED. So there are a diagonal branch which shows also normal, and a little branch shows the evidence of clot. So here shows the mechanism of acute MI, that is the thrombus in the aneurysm of proximal LED. So question is open, how we will do next? Yes, this is the view of iliocranial. So how to proceed?
So what's your opinion? Do you like what next step do you like to do? Your opinion.
Sorry, you were asking me. I'm sorry, I was asleep. I'm not an influencer these days, but I think, LEDs, obviously, at the junction of LM and LED, there is a bit of dilatation, which seems to be a kind of dissection of some sort or aneurysm of some sort.
Dr. Langriyar, your plans for the next step, apart from playing with the mobile?
Could it be a dissection also? That's what I was thinking about, because
You think this is a dissection over here?
maybe, yes.
Maybe. Okay, let's see what happens next. You are privy to the case. You are privy to the case.
But it's a very challenging. You see, then this is a difficult one.
Yeah.
Okay, let's see what you did and what was the point.
So there was no channel to LED, there was no retrograde filling from left or right system, huge aneurysm. So as it was acute MI patient, so routine workhorse wire BMW was taken, of which IUS could not cross the lesion with the help of the balloon. Even then I took the whisper wire, which negotiate into the channel, and with the help of the balloon, I was able to negotiate the wire distal into LED.
And when you had the wire in, was the flow established? Because many times in acute cases, the wire, just taking the wire in makes the flow come back.
Yes, so after ballooning at the lesion with the 2 × 15 at nominal pressures, so what we see next?
So this is the establishment of the flow.
Yes, flow was established. It's TIMI 1 to 2 flow with the huge clot burden. So against to the panel, what's the next plan?
इधर प्ले रखो बेटा इमेज को क्या नहीं माइनस करना. So what would be your next line of action over here? Zeros up at the end.
Now this is acute MI. There is clot over there. You have opened a vessel now. Although it's very difficult to deploy any fully opposed stent here because it's an aneurysm there. One option is to do the IVUS to see what actually it is, what's the size of this, how you can deploy a stent there. Again, in acute MI, it is very difficult to go for IVUS theoretically, but in acute MI, we can give, agrastat and then deploy a stent there. Try to put it in the neck so that we can just deploy it. It should not be hanging in the aneurysm.
Next.
Rather than
anything else. But deploying a stent would be the last.
Yeah, I agree with you because that's midnight and it's a primary PCI case. You have opened up the vessel now. The best thing would be to dilate it again and then see the flow. And if it's fair enough, then you can leave it.
So we did the thrombus aspiration with, and this much of thrombus was brought, aspirated. Intracoronary agrostat was given and infusion was started. So this was the flow. Again, there is a huge clot burden. But at night, in the primary CathLab, I have the maximum size of the stent was 4.0 and the balloon was 4.5 or 5 maximum. Here, the size of the vessel is about 8 to 10 and the aneurysmal size is about 14. So, what to do? Which stent?
We should leave this case, give him agrostate for 48 hours and call back this patient after 48 or 3 days and re-see the, because you have already established TIMI2 or 3 flow.
For the question over here is that everyone is sort of was quite clear that of course you are not going to do any further intervention. The point to be reviewed is that what is your choice? Do you want to stick with the 2B3 inhibitor or do you want to go a full-blown anticoagulation, keeping his APTT levels at 3 and then from there moving forward? So what is your take on it? What is your choice for such a patient? Sir.
Yes, I completely agree. See, the problem is there's an aneurysm, the aneurysm formed a clot, and that decided to go distal and occlude the artery. There is no atherosclerosis in these arteries. So again, stenting is out of question. And agrostat, well, it's a fully formed clot, and the platelets are trapped deep inside. So I don't think agrostat is really going to be meaningful here. Cases like this would be one rare case where you would want to give intracoronary TPA and maybe give it several times, and you can establish flow. This is a patient who needs to be on lifelong or persistent anticoagulation. I don't think it's a platelet.
Is that Dr. Tayyib has a point?
Intracoronary TPA, just 2 milligrams would do wonders here, and you can just puncture your balloon, give it through that, or use the same thrombustor and give the ICTPA, and then just leave him on agrostat. You can give him anticoagulation with heparin, but I think agrostat would be a better choice, as the consensus is stenting is out of question. In RCA, they have documented case reports of deploying peripheral stents that can go through a 7 French guide system, like a self-expanding stent. But I'm not aware of anything to be done in the LED. But RCA, yes, they have shown like a 6 millimeter or a 7 millimeter self-expanding stent to be deployed in the RCA.
Yeah, but I would be very reluctant to put a stent in.
No, not at all. This is out of question. This is
one more point that was just before we going to start showing you what we finally did. One thing was to be asked was that how many of you would consider, if you have the inventory, of course this is the question of inventory, how many of you would consider having a higher French go in and a peripheral thrombectomy device coming in? How many of you would consider, if you have the inventory?
angiogen.
Perfect. And so, okay, let's see what you did finally.
Yeah, just wrap it up, please. We have to start the next session. Everyone is waiting.
So, please, 15 minutes late start.
Sorry, that's we have to finish our time.
Okay.
Patient was put on agrostat for 48 hours, as sir advised, and dual antiplatelet therapy, anticoagulation. So, patient was pain-free, no hemodynamically stable, so shifted to the CCU. And after 4 days, we did the check injection, and what we got now. Totally occluded, again LED with evidence of thrombus there.
Is ST settled or they went up again or no?
STs were not settled. It was about 1 to 2 millimeter elevated.
ST is never settled even in after the first.
50% resolution, like
No, they don't.
very good flow.
Let's keep going.
At
Please,
that
we have to
time,
finish.
we had STs, settled STs to about 50%. And patient was pain-free and hemodynamically stable when we shifted the patient to CCU.
Please go ahead, just finish it quickly. We have to start the session.
Okay. So we referred this patient for cardiac surgery.
Yeah, I wouldn't have referred for surgery after that long. It's probably dead already, infarcted tissue. So I don't know. This is my personal thing, but I would be very reluctant. This has been closed for more than 24 hours. I would definitely document viability or something before I would consider that. But anyway,
Obviously,
I think
work has
we
been-
have to stop, unfortunately. I'm sorry.
You're perfectly right. That's the whole plan, is that we will be doing our viability studies, and then if more than 5 by 10 viable, then we'll be pushing in for a cabbage, so that whatever we can salvage, it can be salvaged. Thank you for this breakfast session, and hope we have a great learning. Today, from Punjab Institute of Cardiology, after about another hour or so, you'll have intermittent 3 hours of live telecast coming from our center. I hope you enjoyed. There are a lot of challenging cases coming on for your good vision and analysis. Thank you.
Thank you very much, Dr. Bilal and the panelists. Good session.